Neurosarcoidosis, a full review. Definition: neurosarcoidosis is a manifestation of sarcoidosis in the central and/or peripheral nervous system. Sarcoidosis is a multisystem granulomatous disease of unknown etiology, characterized histologically by non-caseating granulomas. Epidemiology: occurs in 5 to 15% of sarcoidosis patients. Isolated neurosarcoidosis, without systemic disease, occurs in 10% of cases. Slight female predominance. Peak incidence in 3rd-5th decades. More common in African descent. Pathophysiology: granulomatous inflammation affects the CNS, meninges, cranial nerves, or peripheral nerves. Non-caseating granulomas cause disruption via mass effect, inflammation, or fibrosis. Autoopponent triggered by environmental factors. Clinical presentation: highly variable depending on the site of involvement. 1. Cranial neuropathies, most common. Facial nerve palsy, unilateral or bilateral, is the most frequent. Optic nerve involvement may cause vision loss. Other nerves: trigeminal, vestibulocochlear, oculomotor. 2. Meningeal involvement. Chronic basilar meningitis-like symptoms. Headache, hydrocephalus, or a septic meningitis picture. 3. Parenchymal lesions. Mass-like lesions mimicking tumors. Seizures, hemiparesis, cognitive changes, psychiatric symptoms. 4. Spinal cord involvement. Myelopathy with sensory motor deficits, bladder bowel dysfunction. 5. Peripheral neuropathy. Mononeuritis multiplex, small fiber neuropathy, or Guillain-Barré-like syndrome. 6. Hypothalamic pituitary axis. Diabetes insipidus, amenorrhea, hyperprolactinemia. Diagnosis: clinical suspicion, based on neurologic symptoms in a patient with systemic sarcoidosis or isolated neurologic presentation. 2. Imaging: MRI with contrast is the gold standard. Leptomeningeal enhancement, T2 flare hyperintensities in the brain or spinal cord, cranial nerve enhancement. 3. CSF analysis: elevated protein, lymphocytic pleocytosis, low glucose, rare. Elevated ACE level, low sensitivity, specificity. 4. Biopsy: non-caseating granulomas on histopathology, neural tissue biopsy if safe, or extraneural site, e.g. skin, lymph nodes. 5. Other tests: serum ACE, non-specific. Chest CT or PET CT to assess systemic involvement, rule out infections, TB, fungal, neoplasms, vasculitis. Diagnostic criteria, modified Zajic criteria. 1. Definite neurosarcoidosis. Biopsy-proven CNS sarcoidosis with compatible clinical radiologic features and exclusion of other causes. 2. Probable neurosarcoidosis. Clinical and radiologic features plus biopsy-proven extracranial sarcoidosis plus exclusion of other causes. 3. Possible neurosarcoidosis. Clinical and radiologic features only. No biopsy, but other causes excluded. Treatment: 1. First-line corticosteroids. High-dose oral prednisone, 1 milligrams per kilogram per day with slow taper. IV methylprednisolone for severe presentations. 2. Steroid-sparing agents for relapse or steroid dependency. Methotrexate, azathioprine, mycophenolate mofetil, leflunomide. 3. Biologic therapy, anti-TNF agents, infliximab, adalimumab for refractory cases. Rituximab may be used in selected cases. 4. Symptomatic management, anticonvulsants for seizures, hormone replacement for pituitary involvement, physical therapy and supportive care. Prognosis: variable. Some recover fully, others have relapsing or chronic progressive disease. Poor prognostic factors: isolated CNS involvement, delayed treatment, extensive spinal cord or brainstem disease. Differential diagnosis: infectious meningitis, TB, fungal, multiple sclerosis, CNS lymphoma, vasculitis, neurosyphilis, primary CNS tumors. Key points: always consider neurosarcoidosis in patients with unexplained neurologic symptoms and systemic granulomatous disease. Early MRI and biopsy are key to diagnosis. Requires a multidisciplinary approach: neurology, rheumatology, and occasionally neurosurgery. Long-term follow-up is crucial due to relapse risk.